Welcome to Board Pearls. This is episode 1 of 3 of the Autoimmune and Cholestatic Liver Diseases chapter in the Liver Disease module. This episode is the sorting framework and autoimmune hepatitis, distinguishing the 3 immune liver diseases by antibody pattern and biliary involvement. Autoimmune hepatitis as autoantibody positive interface hepatitis with its type 1 and type 2 split, and treatment with corticosteroids plus a steroid-sparing agent. The 3 classical immune liver diseases share one frame and split on one variable. The frame is loss of tolerance to a self-antigen on a particular cell. The variable is which cell the immune system attacks. Autoimmune hepatitis is the attack on hepatocytes, primary biliary cholangitis, the attack on the small intralobular bile duct epithelium, and primary sclerosing cholangitis, the attack on the larger intrahepatic and extrahepatic ducts. Once the target is named, the biochemistry is predictable. Hepatocyte injury gives a hepatocellular pattern with the transaminases elevated and the alkaline phosphatase relatively preserved. Small bile duct injury gives a cholestatic pattern with the alkaline phosphatase elevated and the transaminases only modestly raised. And large duct injury gives the same cholestatic pattern with one trap, that in sclerosing cholangitis, the alkaline phosphatase fluctuates and is often normal at any single check, so a normal value doesn't exclude it. The demographics close the second discriminator. Autoimmune hepatitis is female predominant, roughly 4-to-1, with a bimodal age distribution in the late teens to 20s and again in the 40s and 50s. Primary biliary cholangitis is even more female skewed, 9 or 10-to-1, with a mean age at diagnosis in the 40s. Primary sclerosing cholangitis inverts the picture, mostly men, mean diagnosis around 40, and bound to inflammatory bowel disease, since the majority of sclerosing cholangitis patients have concurrent IBD, predominantly ulcerative colitis, though the reciprocal rate is small, only a small percentage of IBD patients developing it. The antibody panel closes the sort. Autoimmune hepatitis is the ANA and anti-smooth muscle disease, with anti-LKM1 and anti-LC1 marking the rarer type 2 mostly in children. Primary biliary cholangitis is the anti-mitochondrial antibody disease, positive in about 95% of cases, with the subtype against pyruvate dehydrogenase the most specific, and primary sclerosing cholangitis has no diagnostic antibody, since the atypical p-ANCA is positive in most patients. The IgG profile reinforces the same sort, with polyclonal IgG tracking autoimmune hepatitis and built into its score, polyclonal IgM tracking primary biliary cholangitis, and IgG4 elevation pulling toward IgG4-related cholangitis. So 3 patients sit in front of you and the reflex pattern is the teaching. A middle-aged woman with a hepatocellular pattern, smooth muscle antibody, and elevated IgG is autoimmune hepatitis until biopsy proves otherwise. A middle-aged woman with cholestatic biochemistry, fatigue and pruritus, and a positive mitochondrial antibody is primary biliary cholangitis, and you start R-sodiazoxycholic acid, and a man in his 40s with ulcerative colitis and a cholestatic pattern needs an MRCP, where the multifocal stricture pattern. The temptation is to anchor on biochemistry alone, but mixed patterns are common, so pattern plus demographics plus antibodies sort the 3 within the first 2 sentences of the vignette, and that's the backbone of the chapter. That brings us to autoimmune hepatitis on its own terms. It's the immune attack on hepatocytes by activated T cells, responding to self-antigens that escape tolerance, with the B-cell-derived autoantibodies serving as markers rather than effectors, genetic at base with HLA susceptibility alleles, and triggered by a virus, drug, or environmental exposure in primed hosts. The presentation has 2 phases. The acute phase is transaminases in the hundreds with variable jaundice, sometimes looking like a viral hepatitis, and the chronic phase is an incidental transaminase elevation in an asymptomatic patient or cryptogenic cirrhosis discovered late, with a substantial fraction already cirrhotic at diagnosis, which is why it has to be considered early even when the labs look indolent, since the reflex to delay biopsy and watch the numbers is the one that costs the patient an organ. 2 serologic types matter. Type 1 is the classical adult disease marked by ANA, smooth muscle antibody, and the less common soluble liver antigen antibody, female predominant with documented overlap. Type 2 is less common in North America, mostly in children and young adults, marked by anti-LKM1 and anti-LC1, even more female skewed, running more aggressively, presenting with acute liver failure more often, and clustering with the autoimmune polyglandular syndrome, so the young woman with type 1 diabetes who arrives with 2 weeks of jaundice. The diagnostic framework the boards test is the simplified scoring system, 4 parameters and a small set of points. Autoantibodies score points scaled to titer. IgG scores points scaled to how far above normal it sits. Histology scores points for being compatible or typical. And absence of viral hepatitis scores points, with a total of 6 probable and 7 or more definite. The score has a known blind spot because a meaningful fraction of confirmed patients score 6 or less without histology, and a meaningful fraction are seronegative for the conventional autoantibodies. So the diagnosis in those patients hinges on histology with elevated IgG and exclusion of competing causes. And the score doesn't replace biopsy. It points to it, and the biopsy settles the question. Histology is the diagnostic anchor, with the hallmark being interface hepatitis, where the inflammatory infiltrate breaches the limiting plate at the portal lobular interface and produces piecemeal necrosis. The infiltrate plasma cell rich in most cases with lobular hepatitis common, and 2 ancillary features adding specificity: emperipoiesis, one cell engulfing another with both surviving, and hepatocyte rosettes, clusters of reactive hepatocytes surrounded by inflammatory cells, with eosinophils sometimes present. Treatment is the second half. The structure is steroid-based induction with steroid-sparing immunosuppression for maintenance. Induction in a non-cirrhotic adult is prednisone at 30 to 60 mg daily, with azathioprine added at 50 to 150 mg daily once a TPMT level is checked. And the check matters because TPMT deficient patients metabolize azathioprine to toxic levels and develop severe myelosuppression, so it happens before the drug, not after the cytopenia. The steroid is tapered over 6 months to a maintenance of 5 to 10 mg once biochemical response is established at a few weeks, and azathioprine takes over maintenance. Budesonide at 9 mg daily is an alternative induction agent for non-cirrhotic patients because of its high first-pass metabolism, which reduces systemic side effects, but the exclusion is critical. It must not be used in cirrhosis because the portosystemic shunting bypasses the first-pass effect, lowering efficacy and raising systemic exposure, so cirrhotic patients on budesonide get the worst of both worlds. Acute severe autoimmune hepatitis is a different situation. The hospitalized patient with very high transaminases, jaundice, and a rising INR is treated with high-dose prednisone or intravenous methylprednisolone, without azathioprine and without budesonide in the acute phase, with response assessed every 1 to 2 weeks, and failure to respond in that window is a signal to refer for transplant, not to escalate the dose because the patient who doesn't move on the labs in 2 weeks of high-dose steroids won't be salvaged by week 3. The endpoint of therapy is biochemical and histologic remission, biochemical being normal transaminases and normal IgG, and histologic remission lagging the biochemical by many months, which is exactly why immunosuppression shouldn't stop the moment the transaminases normalize, since the dominant teaching error is premature withdrawal, because most patients relapse within a few years of stopping, and recurrent relapse drives cirrhosis and mortality. So the standard is to maintain biochemical remission for at least 2 years before considering withdrawal, with many experts repeating a biopsy first because patients with normal histology relapse less. So the patient who's been in normal range for 8 months wants to stop, and the answer is to keep going, while the patient with 2 years of normal labs and IgG can be considered for withdrawal, ideally after a biopsy confirms histologic remission, and even then a meaningful fraction relapse and need to know they may have to come back to the drug. Drug-induced autoimmune hepatitis is the named exception to lifelong immunosuppression, because nitrofurantoin, minocycline, methyldopa, hydralazine, a statin, and the immune checkpoint inhibitors can produce an autoimmune-like phenotype that remits with drug withdrawal and a steroid taper without long-term therapy, with the histology identical to idiopathic disease, which is why the medication history is the discriminator. A few practical pieces complete it. Mycophenolate is the preferred second-line agent for azathioprine intolerance or non-response, with calcineurin inhibitors and rituximab for refractory disease. And the most common reason for early treatment failure is not the drug but the dose, since too rapid prednisone reduction and non-adherence dominate, so the move is to re-induce and re-engage rather than switch agents. Pregnancy is where the rules look most counterintuitive. Both prednisone and azathioprine are continued, because the risk of a flare on withdrawal exceeds the fetal risk, and postpartum flare is common, so the right answer for a stable patient who arrives pregnant is to continue both. And transplantation is the answer in fulminant disease unresponsive to steroids and in decompensated cirrhosis, with acute rejection more common in the first post-transplant year and a minority recurring in the allograft. So the synthesis is short. Pattern plus demographics plus antibodies sort the 3 diseases in 2 sentences. Autoimmune hepatitis then has its own logic. The immune attack on hepatocytes in a middle-aged woman with elevated IgG and ANA or smooth muscle antibody confirmed by interface hepatitis on biopsy. Treatment is steroids and azathioprine for induction, maintained on the steroid-sparing agent, with type 1 the adult disease and type 2 the pediatric, more aggressive disease with anti-LKM1. The score points to biopsy. The biopsy settles the diagnosis. Maintenance runs at least 2 years, and withdrawal is cautious because relapse is the rule rather than the exception. Episode 2 picks up primary biliary cholangitis, the mitochondrial antibody-positive cholestatic disease in a middle-aged woman, with ursodeoxycholic acid first line, the changed second-line landscape after obeticholic acid was withdrawn from the U.S. market, leaving the 2 newer agents, and the pruritus management sequence of cholestyramine, rifampin, naltrexone, and the emerging bile acid transporter inhibitors. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 3 of chapter 20, and I'll see you in the next one.